So, given the district's transition to integrated care and everything that we heard this morning, what is your approach to increase the integration of physical and behavioral health care and related services? And as you answer that, we'd like to hear, knowing that some of you are in other markets, what have you learned from those other markets that you're going to bring here? But also knowing the district is unique in their own way, how is your approach going to be different? So kind of a big question and probably unfair to ask you to keep it brief, but go ahead. So, anybody want to go first?
Hello, can you hear me?
Yes, thanks.
Hi, Raymond to MedStar Panelists, Senior Medical Director, Chief Medical Officer. MedStar is in a unique position because we have our 10 hospitals in our system. Yet in Maryland, behavioral health is totally carved out. So it's a little different than the District of Columbia, being wise, that has integrated. So we're learning and trying to build a lot of the things that were discussed earlier. But what we are doing with MedStar Family Choice DC is that we're really investing in integration. We're doing this by various ways. They're very organic. First, we're exploring the reimbursement possibility of the Z codes, which is really important. We're also fostering collaboration with our provider advisory committee. So we have really actively reached out to providers, and if there's anyone in this audience who wishes to participate in any number of advisory opportunities with MedStar, please just hit me up with an email. You can speak with our organizers at HMA, or just email me. We would be happy to speak with you and hear what are your touch points, things that are really important to you. We have various committees, our quality committees, our provider advisory committees, and this is a bi-directional opportunity for us as a health plan, as a provider of health for our hospitals, really hear to the plan, but also for our participants in the community to let us know really what is important. So that is, I think, really important in terms of some of our approaches. We are looking to work across provider types, and we actually have met with, I personally, with our Director of Provider Networks, Carol Chapman. We have been on this road show that doesn't end, and we've come back for a second visit, third visit with many of you here to really understand exactly some of the challenges that you're facing, or what we're doing great, or what we could do better. I mean, we want to, as we mentioned to Mark Lalota many times at the DC Behavioral Health Association, he's in the back somewhere with the mask and the hat, looking very sinister, by the way. But he really does a great job in really providing a very disarming opportunity for all of us to really just throw it out there and see what each other's pain points are, and also to hear what's really working. So, we are here for each of you to be successful, and that's what we're really doing, is being out in the community, visiting our FQHC partners, and hearing what is really important to you. So that's your 30,000-foot level answer to your question.
And if I may, I can't tell, do you want me to raise my hand, or how do you want me to?
Go ahead, Dr. You do it next.
Okay, all right. So HSCSN, I can't see the audience, but we have the opportunity to work with our provider partners as well. As many of you know, HSCSN, every enrollee has a care manager, and we're fully integrated. So our care managers are actively assisting, promoting, supporting our enrollees, their circle of supports in ongoing physical health and behavioral health services versions, so that we can promote access to whole person care. Many of you providers who we work with, who I talk to routinely, also are aware of our system of care approach, our complex case management process, given we have a pretty concentrated pool of complex enrollees, being the district special needs plan. And so we are interfacing at a granular level on a daily basis around integration and promotion of access to dental, physical health, vision, long-term services and supports, and high-risk behavioral health conditions. Our provider network management team is engaged with our community partners as well in terms of outreach, and we'll be doing more of that as the carving occurs for elements of the provider network who are not already contracted for those specific services. And I think HSCSN has a long history within the district, as you know, and so we have active partnerships with our local hospitals as well as community stakeholders, DRS, CMSA, OSCE, DCPS, DDH, again, to support our enrollees and the providers in meeting the full scope of what our enrollees need. And that also helps us engage around quality, when literature pay for performance, and working to make sure that we can improve communication across all the provider network. So this is kind of what we do all the time, and continuing to promote those processes, part of the collaborative efforts, the DC collaborative. So I think in many ways, probably similar activities across most of the MCOs.
Thank you for the opportunity to talk and the presentations earlier. I think it was a good framing to talk about the transition here, specifically in DC. So, so AmeriHealth, we've been doing ways of integrating physical health into our attribution with our behavioral health providers for a while now. Most of you who are in the room who already have relationships with us probably get these quarterly scorecards around your quality enhancement programs and access to kind of dashboards. And, we very consciously from the beginning of the design of that program included physical health measures that the behavioral health providers are, have an opportunity to get bonus payments from, because we recognize that, even though you may not be the providers that are actually delivering that primary care, you may be the primary medical home for that consumer. And, through your community support, through your care coordination efforts, through your partnerships with primary care, whether it's in-house or with another provider, you have an opportunity to close that gap, right? So we, from the beginning, it's always been up there, and we know that in the slides earlier, it wasn't the behavioral health issues, the real cost comes in the physical health side of things, right? Because we know that if their behavioral health isn't managed, they're not managing their diabetes, they're not getting preventative care, and they're relying on acute care instead of outpatient preventative care. So that's kind of been the 1.0 version that we put in place during this time. But I think, as the talks earlier were talking about, when you move to Carvin, there's an opportunity where you are now managing the total cost of care for these individuals, right? And there's an opportunity to build on what are these kind of upside-only programs right now that are in place to kind of show bonuses that you can receive for physical health, and really look at, if you are the attributed provider that's providing the majority of the behavioral health care for them, how can we look at the whole picture of what's happening in their care, and how can we really better manage their whole person health? So, so I think that kind of goes to some of our other questions later too. But there's going to be even more of an opportunity to really bring in all of the care that this person is receiving based on who they're connected to and where they're getting the majority of their care from. And we've done this in Louisiana and South Carolina and other states where, we have gone through the Carvin process, and there's always that transition period, and I think there's always a bit of that anxiety of going through changes to care and the changes to the regulations, but, I think in both states, they're on the other side of it, and there's a pretty clear path forward for this integrated care, so I'm optimistic that we can get there too.
Well, good afternoon, and we're very pleased to be here. Amerigroup is very pleased to be part of this meeting today. First of all, how you're going to want to get a hold of me. So you take the program, you put a period between Bernard and .Arons, you add that period, you replace the MD with the @ and then add a .com after Amerigroup, and you'll be able to get a hold of me, because you'll probably have questions and you'll want to be in touch. Now, I thought I'd spend just a moment. My journey to this moment has come through a number of professional activities, some with the government, federal government, DC government, some clinical, hospital-based care, community care, student health care, some in research administration. But I tried to put myself in your shoes today and say, if I were still working in one of the places that I've worked in DC before, if I were sitting there as part of the Green Door team, or as part of Anchor Catholic Charities, or as part of Woodley House, or Community Connections, or St. Elizabeth's Hospital, what would I be feeling as part of this meeting? And the image I had was, I would feel like I was at the part of the rolling coaster where you're up, you're getting carried up and up and up and up to the top, just before the either horrifying or thrilling ride down the rest of the ride. And given that, I think there'd be a lot. I want to convey the notion that, to me, this is one of the extremely exciting moments in the progress of the District of Columbia to provide enhanced care for the individuals who are part of the Medicaid program and all of the citizens of the District of Columbia. And it is so good to be part of this major change. When I thought about when has this happened before, I thought back to the mental health reorganization that occurred when St. Elizabeth's was finally moved from the federal government to the district government, and there was an integration. The term integration was used at that point because there was now a broad integration of services. But I also think of the time where we moved at St. Elizabeth's Hospital, we moved to a different approach to care, a different building, a different computerization of the medical record, a different approach to that. And this is, I think, a very positive, a very exciting time, and I look forward to partnering with your groups, with your organizations, to make sure that you have the tools to bring a better level of care and treatment for the individuals who are in your care. The other image I had was, how will we know when we get there? And to me, I was thinking about what people experience when they phone, when they call any of our any of our numbers. And it, of course, is our selections have changed, so please listen to all the options. But then it says, if you are experiencing a health emergency, hang up and dial 911. And of course, where does that lead to? That leads to just what we're trying not to do with this change. It leads to someone coming, picking you up, and going to the emergency room. So where I would like to keep track of is when the process of calling one of our organizations occurs, is if you're experiencing a health emergency, we will be with you right now, and we will make sure you get the care and treatment and the response that you need, so that you get what you need now, and hopefully you can get that in your home or in the clinic that you've been going to, and that's a measure that I'll look forward to, while understanding that the lawyers may still require that statement on our comments. Thank you.
So let me do a follow-up question. So if I'm a behavioral provider and I want to communicate to the patient's assigned PCP, how do I know who that PCP is? It's probably even more challenging if that PCP needs to refer to being as the attributed behavioral provider. How enrolled in the plan? What are you doing to facilitate exchange of information between the primary care providers and the behavioral providers?
Well, I'm going to go back to your presentation earlier where you were really highlighting how sophisticated our crisp health information exchange is here in the district. Because, while we have on the health plan, everyone has that attributed PCP that's assigned to them on the card. But we also know in the district, patients have choice. They can go, they don't have to go to that attributed PCP. They can go see who they want to see. And so really the best source of information for that real time, who is the care team that is connected to this individual would be crisp. And I know we've made a lot of progress in terms of our behavioral health providers really accessing that tool, and at a stage where they're sharing more information there too. So I think that's in a lot of our conversations with providers, it is very much how are you using and leveraging this tool to your benefit beyond the ADT reports, but all of the other very sophisticated information you can get from there, especially the most updated demographic information too, which you probably that you would find there. Yeah.
Anyone else want to comment? Yes.
Sure. Hi. What we did here at MedStar, because I'm not at MedStar now, I'm sitting here with you, but back in the mothership, we looked at touch points for our enrollees. And there are a number of touch points. ED is an extreme example. But we looked at our welcome calls. We have a very nice welcome call program through a CBE. Which we call every new enrollee to our plan. It's about 1,000 or so, but we have 1,000 new enrollees every month. Some fall off, but we have 1,000 new people. And we call this, you've heard 9 to 5, right? The movie? Well, we call this 3 in 1. So we do a welcome call to all 1,000 new people in our plan. And we do 3 things. One, we do a health risk assessment, a social determinants of health assessment, and the third one you will like, and that is a primary care visit. That's the 3, and the 1 is in the first month. That's the objective. So this is something new, and so when we actually reach an enrollee, we know that number works. So that validates that information, because so much of what we know from the redetermination is that information was not always accurate, because numbers change, people's addresses, if they have one, change, and that information was often inaccurate. So we've instituted this 3 in 1, and that gets that person engaged in the primary care very early on in the journey, and that creates that relationship. So when we met with Unity, when we met with Whitman Walker Health, when we met with So Others May Eat, when we met with all the FQHCs, they're really excited to hear about this. That's a touch point. The other thing that we did are doing at MedStar is that we had a pilot for 6 months. We ran a pilot where we actually had one of our community health workers, which you mentioned, at MedStar Washington Hospital Center. That's an advantage of being a health plan and a provider of health, is that it's kind of easier to kind of get these things through the process. So we had during business hours, Monday to Friday, a community health workers sitting at not United Medical Center, that's what it used to be, at the Washington Hospital Center. And what we found was that it decreased ED revisits because that community health worker bonded with the enrollee. Now, the entry to this pilot was 3 or more ED visits within the year. So we were screening for those ones who tend to come a lot. And our CHW bonded with that enrollee and got that individual into all the elements of care that are needed after they get discharged from the hospital, and it really was successful. The other thing we did was with the primary care visits, when applicable, we walked them down the hall to MedStar's primary care visit. And those people who got into this pilot and had a MedStar primary care was a 96% completion of that primary care visit. So that was a pilot, and now we have a program. We actually hired a new community health worker who is going to be at MedStar Washington Hospital Center, and we hope to do this at the other big hospitals as well. So to answer your question, it's that relationship building, is so critical with that enrollee.
So I think all of the MCOs will be doing many of these things in a similar fashion. Another that Amerigroup DC does, and I'm sure the other MCOs will do as well, is we want to make sure that you will have the kind of information and data that we have so that we can work together to accomplish enhanced healthcare for the enrollees who we share. And it goes back to the presentation earlier, when I put myself back in the place when I was working in a community clinic and prescribing. I might prescribe to someone, answer questions about their medication, and then set an appointment perhaps a month later. But I would never know whether that medication was filled until that month came by. Now I get every week a report of anyone who was prescribed a medication, should have had it refilled at a certain point, and where it was not refilled. And that information will not only be followed up by our folks who will be working with the enrollees, but information to go to you as well. In a similar fashion, we expect someone on an antipsychotic medication to have certain follow-up for their healthcare needs and certain lab studies done. And we have the ability to assure that that occurred and not necessarily wait until it emerges that it hasn't been done down the road. So we try to tie that together and in a way that not only we're aware of, but you will be aware of also to enhance the treatment and care for enrollees that we share.
Dr. Hall, did you want to make a comment on that question?
I'm sorry?
Do you want to respond to that question?
I was going to say that in terms of HSCSN, the hub of everything we do is the one single care manager who is the conduit support between the PCP, our enrollees, we refer to as enrollees at HSCSN, and all community stakeholders and providers. And so the plan of care, the care plan, contains all the critical key stakeholders and critical support to our enrollees. And we are in the process of implementing an updated care management platform, which will allow better reporting, data sharing, and real-time engagement with providers around trends we see with our enrollees related to follow-up adherence. Our EPSDT team does a great job, and care navigators in coordinating with wellness, preventative care visits. And so I think it's probably similar processes, as someone else said, across all the MCOs. But we actually have a new health record system forthcoming. We're going live this month, which will make that even more robust in a timely fashion, no less.
You got a follow-up?
Sure. So we know that the enrollees who are in an acute psychiatric, who are acutely admitted for a psychiatric issue, are very fragile. They're the most fragile individuals. They are very fragile. And it's not just they just became, the condition just turned on and they showed up at the emergency room or whatever. It's a chronic condition. It's like HIV, it's like sickle cell. It is often a very, very long journey. So we know as a health plan, we can track, which is what we have done through our pilot, our work, looking at the medication history before hospitalization, looking at the medication history during hospitalization, and post-discharge, looking at the medication history post-discharge, were they fulfilled, all that sort of stuff, without getting into all the jargon of the abbreviations. And it's amazing that even though they get a discharge plan that's printed in a piece of paper, we know that those enrollees are really, they don't understand the stack of paper. See Dr. Moghimi at 3 o'clock at Community Clinic. See Dr. Arons at 4 o'clock next week. I mean, they're not going to follow those rules. I mean, it's crazy. These are very fragile people. Yet, Many of these people who had a lot of medication before hospitalization, a lot of medication during hospitalization, have no medication claims post-hospitalization. That makes no sense. So there's something else going on. Now, we know that follow-up behavioral visits and primary care visits and all those, some of those claims are almost invisible to us in some fashion. But the medication claims the health plan covers, and that is really unacceptable. So we're looking at measures to try to figure this out. The pandemic is over. Very few of us are wearing masks. We can visit the hospitals. I'm so glad that most of the hospitals are allowing people to come into the hospital. We got to have our staff being able to go to the hospital, translate the stuff in the binder for the enrollee so that there is a relationship prior to discharge. So that when I'm kicked out to the street, that there's someone there to catch me. We cannot expect someone to take the W bus, the P bus, the A bus, the D bus, the 33 bus to figure it out. It is impossible. So that's why, just like the CHW taught us at Hospital Center, it's so helpful for the behavior health space. That is essential. So I just want to mention that.
So we have a couple more questions here to ask them, but I don't want to run out of time at the end for you all to ask questions. So I'm going to pause for just a minute with my questions and see what you all think. Anybody have any questions or comments?
I don't even know if this is really.
Can you see it now?
Just stand up, please. Maybe probably have to talk a little bit louder.
I'll stop that.
Thank you.
This is for MedStar, and I'm not sure if this is the right forum to ask even, but I was looking for psychiatric care through MedStar, and their behavioral health, there was none. They were like, right now we have no behavioral health, no psychiatric care right now. So although MedStar is great on one aspect, how?
Yes, so after the panel is over, I'll give you my card. I will address your particular concern, but you're right. And that's the wisdom of this integration stuff, is that before it was outsourced to a third party, to another party, Magellan. So everything is now within MedStar. So let me speak with you and I will sort it out, but believe me, the lights are on and they're bright, okay? Thank you.
I see a question in the back there.
Yes.
Oh, and the Dr. Best right next to
I mean, just a comment. I'm Dr. Kera from Nova Caritas. The comment goes directly to MedStar. So we are still waiting for the fully executed contract with you guys. So I know during the transition with Magellan, we submitted all the paperwork, right? So, and then you guys were supposed to follow. But so far, I've signed all the documents. It's been like 2 months today. I did not hear from you guys, so I don't know.
Okay, right.
Only one, or everybody has the same?
So after this panel is over, I'll give you my card. So Carl Chapman is our director of provider networks, and there is a vendor who is doing all those processes. If the application is clean, it goes for it very quickly. But yours, I don't know. But let me find out. I'll be happy to sort through it. Okay.
I want to go directly to Amerigroup, please, if you don't allow me. Amerigroup, we welcome back to the district. So we had application before you guys left, and since you guys came back, are we following up with the same contact, or was it extended? Please.
Do you mind
So,
if you just want
that
to
can
repeat
repeat the
that so
question.
Yeah, that's
that
right.
Kate picks it up better? Would you mind just, or as you answer, could you summarize what the question is so we can get it on the table?
Sure. Well, that immediate question was, Amerigroup was part of the MCO array from 2017 to 2020. We're now back in 2023. What about a provider who was contracted back in 2017 to 2020? Is that brand new? No. Everyone who was contracted, we maintain those contracts continually. Now, it may be that you have individual providers who have come or gone, and individuals who need to be credentialed and go through. So we are also on a road show to try to meet with every provider to make sure that any turnover of providers is documented and those individuals are credentialed, but there's no need for a recontracting if you had a contract before.
Thank you. Dr. Baker.
I just had a comment, and my comment is there was a lot of discussion about the interoperability and data sharing, and one of the requirements that DBH has for certification for the Certified Provider Network is that you must have bidirectional connection to CRISP. That means not only do you have to receive information, but you also have to put information in. And the reason for that is to try to support this whole person care integration of services. And I think that's an important point to raise so that nobody is really confused. That is one of the requirements to be a certified provider.
Thank you.
I just want to jump on that real quick. We do have funding to support you.
That's right.
And EHR. So fortunately for us, for our HCBS ARPA funds, the digital health technical assistance, I see heads again, so this sounds like everyone's getting the message. I know we've had at least a dozen or two, and I may be really under that number, within the first few weeks, has signed up and getting financial support too. But please don't miss this opportunity. It's just what Josh mentioned earlier, how all that initial funding from the federal government completely accepted behavioral health providers and other really key core Medicaid providers. And with this opportunity, we're trying to make sure that you guys have that support as well. So if you have a question about it and you don't know about it, you can just email me directly and I'll connect you to our staff and the digital health team to make sure you are aware of the opportunity.
Right.
Thank you.
And if you don't do that, you don't get certified. Let me just say that.
I see two questions in the background. Lisa Gilman from DHCF.
Thank you. I just wanted to add to what Mr. Burgess said. On our integratedcaredc.com website, under the training programs, there are descriptions of all the programs that stated and contact information about this number.
If I didn't make enough shameless plugs about the website, it's integratedcaredc.com. There was another question in the back?
Yeah.
All the way back. Thank you.
Hopefully you can hear me. This is for MedStar, but then this is also a question for all the MCOs. You mentioned the touch points project process program where you work with providers to help with enrollment and navigation and make initial assessments. I'd like to learn more about how you identify providers that you work with to support that effort. And do other MCOs also have processes or projects that you're exploring in terms of entering your insurance plan? And the other question is tied to that, which is MedStar also mentioned you are investigating MCOs and how we can potentially support the business that way. I'd love to hear much more about how you are planning on doing that exploration, or you invite voices in that process, just a little bit more time.
There was a question about provider and the point system you mentioned. And then
That's a really good question. So what we have is these forums, these open forums to discuss with providers things that are important to them, like is there a need for this particular provider, or what do I need, or those sort of things. So if you want to just share your information with me, we will invite you to be a part of that. But certainly it is open to all of our providers. And the other thing is that we have a provider newsletter and an enrollee newsletter. In fact, it's just being tidied up right now. And it's all electronic, it's online. And there are lots of clicks and options on those electronic newsletters that allows you to send us questions specifically to what might be of interest to you. So I will share that information with you. But that provider newsletter and the enrollee newsletter is open really to anybody. And there is a way to send us questions so that we can really focus the response to what's really on your mind.
I'll pause for a minute and turn it over to Dr. Hall to see if you want to respond to that. There was a question about, I think what I understood to be is how the MCOs are reaching out to the providers to get them engaged and to help them understand what their responsibilities are and how they will work with the plans. So So outreach to providers more than outreach to members.
So, the agency is in our provider, oh, can you hear me?
Yes.
Yes, thank you.
Yeah, thank you. Our provider network management team, will conduct outreach as they do ongoing with, providers in the community in order to determine, their readiness, address questions. In fact, one of our provider network management team leads, Lydia Mason is there. Raise your hand, Lydia. I can't see you, but folks in the room can see you. So that you can connect with her. You can certainly reach out to me. I'll drop my phone number in the chat. Everybody else in the district has my number. You can call me too. I'm going to send you to our provider network management team because they're the ones who provide ongoing education, support, technical assistance for providers in our network and in preparation for the target as full-service agency providers expand coming into the network. We already have full-service agencies in our network. We already pay claims, of course, but it's going to get to the world when there's prior authorization and there's certain services that have not been under contract will come in under contract. And I think the other piece around education is going to be important between now and go live is understanding about HSCSN and not just the provider performance expectations and claims payment and utilization review, authorization requests for those who are not accustomed to that. But also our focus on quality care, what it means if you have not been engaged with entities who are, NCA accredited and or other accreditation and regulatory body performance expectations. Anybody who talks with me, and many of you in the room may have spoken with me in the past or this week, know there's a big focus on access to evidence-based treatment. Our whole big mission around 730 follow-up to hospitalization and how we approach that to improve engagement for our enrollees. So there is a plethora, a wealth of information about partnering with HSCSN for our enrollees, for our providers, that we will continue to engage with outreach for our behavioral health partners in the district.
Thank you, Dr. Hall. Dr. Moghimi and Dr. Arons.
So I just want to remind folks of some things that have been mentioned before, other channels for communication and for problem solving between the providers and the MCOs. For those who are active with the DC Behavioral Health Association, we all are part of the discussions, and you can use that as a way to address problems and resolve them. We also, as was mentioned before, each of the MCOs has a provider advisory committee, and if you can handle one more meeting or have someone in your organization who's willing to attend another meeting periodically, ours are once a month and usually after 5:30 to 7 time, we very much benefit by having a behavioral health provider as part of that provider advisory committee, and that information can then be brought back to other providers in your organization and throughout the community.
The only thing I'll add to the similarities in terms of the provider advisory council and the account executive is we also one of the things that was highlighted earlier is that we sit on a lot of data, right? And we know how to risk stratify, we know how to kind of identify emerging risk, and part of the goal is how do we really get that information to you all, and how do we help you understand how we think as a health plan in terms of how we manage populations based on risk, which I think is one of the exciting parts about the transition. So, we have, I don't think she's here, but practice transformation manager, Kelly Johnson, that really is kind of like that in-between person between, here's all this data we're sharing for you on our dashboards, and how should I interpret this data? What should I do with this? How can I build out workflows that can help improve the population that I'm managing? So that's another key point person in terms of having that provider. We want to have our conversations be driven by data because that's what we have. We have a lot of it. So, and the integrated care DC team has partnered with us in a lot of those provider conversations too. So another plug for you.
as well. Those are shameless plugs.
Can I mention something about the data real quick? It's real quick. Okay. So, you know, the Unity Clinic, their pop health guy is sitting over there, Andy. The organizations like Unity are really doing great work, and they have their own data, and they're making their own dashboards. So what we're trying to do, and I'm sure you guys are too, is to work with the organizations that are really, you know, 5 stars, recommending to a friend type of place, and build the dashboards that are really concordant with what other people are already doing. It doesn't make sense to make our own little dashboard and say, do it this way, if you really haven't talked to the providers to say, well, what are you doing? How are you doing it? What will be valuable for you to see from us, so that we can make sure that there's concordance with something that they're already prioritizing with what our priorities are. I think that's good business sense, but it's also good health sense.
Thank you. So, you know, when I ask for questions from the group, I kind of get 2 looks of faces. One is, I have so many questions, I can't pick which one. I wouldn't know where to start. I couldn't formulate a question at this point. Or you're like, I don't have any questions. I don't know where to start. So, what would you all tell providers? And when they go back to their offices tomorrow, or they talk to people that weren't here, and they say, what did you think of that workshop? I know you're going to say the lunch was fantastic. But what is it that you want providers to have learned today? What is the key takeaway? Because we've given them more information than they can remember. So if they say, you know, even the best part of the day was that panel. And what I've heard from the MCOs was what? And I know they've got your email now, but besides your email, what is the takeaway? What do they need to know that they don't know? And I'm going to start on the end down there, if you don't mind.
Sure. So some of the messages that I've heard today that I've taken away is this is going to happen. This is happening.
That's
so,
right. That's right. It's going to happen.
So there's a point to be made about let's embrace it. And the other point that was made earlier today is I hope we've conveyed that we're not the enemy. We're in it to partner to make this happen, and our job can be done better if your job is going smoothly, and we'd like to work on doing that together.
Okay, so he talked about partnership. You got to say something different.
Can't say partnership. Sorry. Well, I guess I'll build on partnership, because I do think that there is an opportunity here where we're really talking about, you know, the whole person that's there in front of you, right? And I like that image earlier that was shown where it was the decapitated head for the carve out, right? Because unfortunately that is just the way that things have operated for so long. We're not taking care of this whole person here. And so, our goal is to be able to say, when you have that person there in front of you, like, what are all their physical needs, behavioral health needs, social needs? What are the things that the MCOs have that we can support you in? I'm always shocked that, I feel like we've got a very robust benefit in DC in general, and then a lot of the MCOs have their own value-added benefits that we're doing to address social determinants, like home meal delivery, like Lyft rides to your medical appointments, like, we have a very robust, generous Medicaid plan in DC. It's not like this everywhere in the country. So we really have the opportunity where we can be knowing what all the needs are of this person sitting in front of us, and you are the point person, and we trust you to build that relationship with them. The health plan is always going to be once removed. But we can help give you the data, we can help give you some additional benefits, and hopefully make the process as seamless as possible so that you can do the work that you all are here to do.
Hi. So, quick. Okay. So, you want to go?
Dr. Hall, do you want to jump in next?
Sure, actually great. All the other things are going to be used up when we're last. No, I will say that I would want the providers to know, those who have not worked directly with us already, I think all MCOs come to this table with the same spirit. We are doing this because we care about the care, the progress, the support of children and adults within the district for their whole person needs, as someone else said. I think what we get with HSC is we're going to collaborate. This is in the spirit of we work for our enrollees and enrollees don't work for us. We want to collaborate with our partners across all agencies, providers, everyone to address barriers, to empower our enrollees so that they can be their own best advocate, although they will have an advocate with us as well. And we understand the system is complicated. And however we can take advantage of the lowest hanging fruit for providers and for our enrollees so that we can meet common goals is what we're going to do.
Well, everything is what was taken away. I don't know what to say. But I think all of us here, all four of us here are working together. I mean, we're not competitors, we're collaborators, all the plans, right? I mean, that's why we're spending the whole day with you. But also the plans, and I'm sure I speak for all the other plans, we want you to be successful. I mean, it doesn't make sense for you to be unsuccessful. So if there's something that is making you less successful, you gotta let us know. And just call me, email me, text me. I mean, Dr. Moghimi is very accessible. I mean, everyone's accessible. So we want you to be successful, and that's, I think, an important element. And, you know, Dr. Bassaron has been here a long time, and she's very committed to the district residents. Melissa, the same way, very committed. And so they want us to be physically responsible with the head attached, but also fiscally responsible. So that's why it's a collaborative effort. And so we're here to invest our time for the city's resources. Because I'm a DC resident, I'm a DC taxpayer. I want my tax revenue to be spent for good outcomes. And so we want you to be successful.
All right, thank you. I have one more question, and then I'm going to turn it back out to you. So speaking of fiscal, one of the questions that we wanted to ask about is we started the day to talk about the imperatives of payment and practice transformation. So we've heard a lot about practicing differently and partnerships, but what about the payment side? What about the value-based payment incentives? How are you going to incent providers financially to be part of this integration movement? Where are the opportunities in what should they know? Dr. Moghimi.
Yeah, I mean, I think I touched on this a little bit earlier, you know, and for those of you who, again, Kelly Johnson's our practice transformation manager and kind of walks providers along that land sort of spectrum of alternative payment models, you know, so there's a lot of data out there around. You can't all of a sudden just pull the rug out of providers and say, you're in a full risk contract and you're managing this population and you know, hope it goes well. It doesn't work that way, right? You have to have this roadmap to get there, and so there's a very clear progression in how you can do that, and how, you know, and a lot of it does have to do with data and how comfortable you are with the data and how comfortable, how reliable is the data. Do you trust the data? Do you know what to do with it? And so I think we're already setting a foundation for that with the work that we're doing, and you know, it's going to be an ongoing conversation with providers one-on-one, and providers can come to us with proposals if you feel like you're saying, well, we're ready. I mean, I think tomorrow I have a meeting with a provider that says, you know, we want to move to that direction of taking full risk for a very complex SUD population. That's great. Like, you're ready. If you're ready to go that direction and you feel like you have the data and the team to do that, like, that's the direction that healthcare is going. You know, that train has sort of already left the station, right? So we're here to support you, but you know, at the same time, it does require baby steps, and we do have to kind of be partnering with each other in that whole process too. And I think, as with most things, you know, behavioral health is always a little bit behind with our physical health providers, but you know, we're going to catch up, and we're going to be able to do the same types of programs that are in place on the physical health side too.
So partners. So what I'm hearing is if there's providers out there that want to get paid to practice differently and get paid differently, you're having this.
Right. Yeah. I mean, there are opportunities where we can start to break the shackles of this fee-for-service mentality, right? And you're like, we want to provide a service that's unique. We think we have an evidence-based model that'll work, but, you know, how am I going to pay for this family peer specialist, right? You could say something. There's a lot of programs like that where it's, you know, the outcomes are ultimately what matters. How we get there, there can be different routes to that.
Sure. So I'll try to just phrase it a little, the same information, just slightly differently. So it starts with claims and payments. Some of the services do require authorization. Some require concurrent review during the process of the treatment. Many services do not. But it starts with the claims and the payments. But then very quickly, a picture develops of how many enrollees you have in your care and what that's costing the district that we keep track of. So we measure our own activities through a number of metrics. We do collect information around follow-up after hospitalization, around adherence to medication, around health of individuals. And we're, again, looking for the opportunity to take those metrics and move them to you so that you can then do your self-measurement, and then we take a step back and allow that process to occur. So that's, if you will, an evolutionary process that occurs over a bit of time in this effort to get out of the incentives that occur when there's a fee-for-service process and more towards something where there's a whole health integrated model that we'd like to get to.
Hi, that is an important question. And the reason why it's important is that every one of you out there who has your own business realize that your payroll's changing, people are making more demands, people want this, people want that, inflation is really a big factor. And to say that your lease or your rent or your service contract for your medical equipment or whatever is this today, you know that next year it's going to be different. And so we are taking baby steps, and we are talking to folks who are really doing this now. Like, for example, So Others May Eat. They're doing value-based type of work. Woodley House, they're doing value-based work. So there are people out there, people meaning providers, already working in this space, and we are speaking with them and saying, how are you doing it? What are you finding? But it could be very catastrophic to make some predictions of what the economy is going to be like in the future. I mean, we're around for 5 years, and the economy is going to be different in 5 years, so we don't know. So, but we are talking, we're listening, and we're really like this. Welcome people's ideas, because those who are doing it better should get paid more. I mean, we really fundamentally believe that. And so we should reward the successes, and the laggards should be given some guidance to improve. So when we spoke to Whitman Walker Health for HIV, they're doing a lot of this stuff already through the Ryan White work. It doesn't make sense for the MCO to sort of organically create some sort of structure and say, do it this way. We want to talk to the ones who are doing great, and those who are doing it great should really set the standard for everyone. So that's what we're doing on the MedStar side, just baby steps and talking.
Dr. Hall, did you want to respond to that question?
Sure. As in other pay-for-performance activities, HSC has already initiated a PDC process for our physical health providers. And we are actually in the midst of an implementation of a value-based contract for a behavioral health provider with targeted metrics. And so I don't have the outcome data on how that has gone. We are literally in the process of implementing it. However, much to my colleagues' comments, this is honestly about no value-based contract is going to ever hold water if it's not achievable by the entities who have to implement it. And so with that in mind and thinking about good outcomes and ultimately the triple aims, we've decided to put in place a pilot project work out the kinks and see where it gets us. So more to come about that. But it is really, I think, a critical element of the direction we're moving in to shift from the rest of the district to pay for performance and really pay for the outcomes and the value and promote good quality whole person care. So we are in the midst of that.
Thank you. Where there's opportunities to incentivize and to pay those higher performing providers, that's what's really behind value-based payment. Otherwise, it's just managed fee for service. You're still just filing claims, you're just sending them to someone else. And the turnstile that Josh talked about really isn't any different if you're not actually paying for providing higher quality care. So I did promise to take one more question from the audience, and I'm going to do that. But I want to say the MCOs have all agreed that someone from their team will be in every one of the breakout sessions. So you have other opportunities to engage with them. So we'll take one more question. I saw a hand up. Thank you.
My question is off of all the MCOs. I integrated the billing and compliance. So one is, are we able to get, a streamlined channel of communication? So for instance, my experience, I send emails out to AmeriHealth about, fee schedule, and 2 weeks later I get a response that, I'm not the right person to contact, I'm going to lose my colleague in, I didn't get a response. So if we're able to get a go-to person, I believe every MCO has a provider liaison officer. I don't have that information. Also, with respect to billing, what's the billing cycle? I also believe that every MCO determines how much they pay providers for services. So coming from billing, what 2 services cannot be paid for the same day? What is the credentialing process for each service? So for instance, can we do an assessment, treatment plan, and can it be cycled out the same day as TB paid for all those services? Claims audit process, who's going to be handling that is a DBH? If we have to with claim denial process, is it going to be you guys, all of that stuff. That's just me.
Okay, I'm going to try to paraphrase some of that. So I heard a question about the point of contact, and that you are asking how to get a more efficient response back. And I think we've gotten 2 of the emails that Dr. Moghimi, if yours isn't already out there, Dr. Hall's. So I'm going to kind of hold on that question a little bit. They've all given, points of contact, and then you'll put people in there. And again, I'm going to pause for just a second, but if you're with one of the MCOs, could you stand up again, please? Great. Okay, so I'm going to ask you to direct some of your questions to these individuals, and they will be in the breakout sessions. And I know you have a lot of other questions about what services are eligible on the same day, questions about claims. I think that's probably more than, that's a lot of detail. But Dr. Bezran, well, do you want to maybe explain some of the other forums where you can get questions like this answered? It's down to the left, bottom left. Yeah.
Okay, yes, there are many other forums where we can address the detailed questions. One is the monthly behavioral health provider meetings hosted by DVH, in which DHCF participates as well. Our integrated care forum monthly meetings, the next one is tomorrow afternoon. And then always you can reach out to Dr. Bazran or myself. A couple direct responses though. One, another bridge policy is for the first 18 months. The schedule, the rates that we have in place after the rate study is completed, that will be, baseline what you can expect to be reimbursed from the managed care plans as we transition. But I want to really make a note, because I don't just hear this with behavioral health providers, I hear from other providers. You said specifically like what the plans pay. And you heard up here, it will be a negotiation between you and the managed care plans eventually. That means you can negotiate more than what's on the fee schedule or not. But I just want to be really clear about that. I don't want you guys coming into this thinking they say X and you agree to X. It has to be that collaboration and partnership for it to benefit everyone involved. So I just want to be really clear on that, because there are different provider groups where I consistently hear that message, this is what the plans pay. It is really, when it gets down to it, should be a negotiation between you and the plans. The better outcomes you can show to the plans, I suspect the better rate you'll be able to negotiate. So just keep that in mind as we go forward. But initially, when we first start with the carve-in, our floor will be set at the fee-for-service fee schedule for the services available to Medicaid beneficiaries. Okay?
The carve-ins, will there be guidances for each MCO? Because I've requested guidances from AmeriHealth, Trusted, and I haven't received it to date. So I think the guidances would help answer those questions and guide us a little better as we negotiate.
Certainly. And one thing I will say, though, is that our new contracts just became effective April 1st. So the focus right now has been not the carve-in for the plans. It has been transitioning to the new contracts and expectations. With that, and leading up to that, is always a readiness and transition period. We will be going through that specific to the carve-in. So seeing the managed care reps today is just the first of many times you're going to see them going forward. The last time we had a transition, this was a population change, not a shift like a carve-in. We'll see the managed care reps at the behavioral health provider meetings. There will be more meetings and contact, and that information sharing will be happening as we get closer to the carve-in day. So yes, a lot more to come. If you aren't receiving the initial response from the MCOs for the work that you may already be doing with them now, and you still don't get traction, then let me know, and we'll certainly follow up and make sure they're being responsive.
Behavioral health manual.
And Dr. Bazran's queuing me up here. The other thing is we go through and we get closer to our actual carve-in, we'll have a specific behavioral health manual too, which will go into the detail, a lot of the details that we've received questions about this morning.
So first of all, I want to thank all of the MCO representatives